Dr. Laura Langmaid is a member on our clinical informatics team based in Dallas, as Sean said. She originally received her BA from Baylor, after which she attended the University of Texas Medical School at Houston, where she received her MD. More recently, she completed her residency with the Department of Anesthesiology and Pain Management at the University of Texas Southwestern Medical Center. Dr. Langmaid has also been active in encouraging physician education in regards to government and healthcare policy. She has participated in patient and physician advocacy on both a state and federal level, and she is very much looking forward to sharing her knowledge with you today. Laura, take it away.
Great. Thank you, Karen, and welcome everyone to the webinar. Today we are going to be discussing two main quality programs. That's going to be the Value-Based Payment Modifier, or the Value Modifier as it's more commonly called. And in addition to that, also the Medicare Access and CHIP Reauthorization Act, or MACRA. Today we wanted to talk with you about how exactly these programs are going to be affecting the Medicare Physician Fee Service, the Physician Fee Schedule, and that's going to be the Physician Fee Schedule that's going to occur under Original Medicare or Fee-for-Service Medicare. Additionally, we want to talk about physician engagement with the patient-centered medical homes and essentially how quality improvement is going to be essential for success in the future with CMS regulations. And of course, we also would like to mention that IBM Watson Health would be able to help continue to support you in your practices in order to maximize your performance, your patient care, as well as your payments. So first, we'll start with the Value-Based Payment Modifier. As an introduction, this was a piece of legislation that originated out of the Affordable Care Act, which was passed back in 2010. And the whole issue that CMS and the HHS is trying to address is the ambition of tying payment to quality. Last year in January, HHS came out with a stated goal that they wanted to tie 30% of their fee-for-service charges to quality by the end of 2016. And then on top of that, they went a step further and also stated that they wanted to tie 50% of payments to quality by the end of 2018. So these two quality programs we'll be discussing today essentially are the embodiment of that goal. So the value modifier, what is it? As we stated earlier, it's an adjustment that's made to the Medicare Physician Fee Schedule based upon two factors. When CMS decided they wanted to assess how care was being delivered, the decision was made to look at quality as well as cost. So bear those two things in mind. These are going to be the pillars for the value modifier program. How this is also done is through a technique called a measure. For example, how many of my diabetic patients received their annual foot exam this year? That's an example of a measure of quality of care. There are also measures for cost of care, which we will discuss shortly. Essentially, after quality and cost have been assessed, a process called quality tiering is then utilized by CMS. We'll walk you through some examples of this process so you can have a better understanding. And the quality tiering will dictate the value modifier. The value modifier itself is that adjustment that is made to the fee schedule. So here's a simple diagram that we developed. You can see quality is on the left, cost is on the right. The word composite essentially just means that it's the sum of all of the measures. So you have the left and the right, your quality and your cost, which are then incorporated into quality tiering and thus decides the value modifier. Here you can see that we've identified that there are multiple quality measures. Many different quality measures may be reported, and we'll go into the sources from which those may come. Those measures are then sorted into different domains. A domain is simply a grouping of measures together because they relate by similar endpoints. For example, patient care or care coordination. Those are going to be some examples of your quality domains. Those domains are then put together and weighted, and thus you arrive at your quality composite. So where does this information come from? Where are these measures being pulled, and how is the data being acquired? There are essentially three sources for potential quality measures. That's going to be your Physician Quality Reporting System, or PQRS, as many of you are already familiar with. It will additionally also be pulled from something called the 3 claims-based outcome measures. And while the phrasing claims-based is in there, and yes, it is derived from billing data, keep in mind that the endpoint of this is an outcome measure. We are still looking at quality even though we are using claims-based information. And then lastly, the consumer assessment for health providers and systems. This is a survey that a lot of y'all are familiar with as well. It's more commonly called the CAHPS survey, and this can possibly be included in the quality measure as well, depending on your program. So let's take a closer look at PQRS reporting. Many groups should already be participating in this, and this is an essential step to successfully participating in the value modifier. PQRS reporting will essentially cause an immediate categorization of all groups based on whether and how they have submitted their PQRS data. And there are lots of different ways to support your PQRS data. There's methods for GPro, web interface, etc. And keep in mind as well for your individual practices or your groups, it's always best to check with the PQR organization themselves through CMS to identify what is going to be your option and what would be one of the more appropriate ways for you to submit that data. The reason that this is so important, as we stated a second ago, is that this is going to cause a classification into Category 1 or Category 2. Category 1 are going to be groups that have satisfactorily submitted their PQRS data. Category 2 are going to be groups which have failed to do so. And so I like to call this the first value modifier hurdle. This is essential because even though PQRS is an independent program, the value modifier draws on this. If, for some reason, a group does not successfully report this data, then there is an automatic downward adjustment from the value modifier. This means that groups fail to be able to participate in the quality tiering program. So keep in mind that this downward adjustment from the value modifier can occur in addition to the downward adjustment from the PQRS system itself. So for our groups out there, this could mean that there are going to be multiple payment penalties annually from the value modifier, from the PQRS, and then don't forget about your meaningful use program, which is going to have an entirely separate set of measures that need to be met in order to have successful completion. So bear in mind this is the first hurdle. CMS is really interested in having groups successfully report this data, and the bottom line is that it's going to have multiple effects as far as how you're reimbursed in different areas. Our second source of possible quality data is going to come from the 3 claims-based outcome measures. So you can see they're listed here. There's the 30-day all-cause hospital readmissions, preventable hospitalizations for acute conditions, and preventable hospitalizations for chronic conditions. So this is data that is actually derived from claims and billing data. There's not typically a submission requirement for groups to do this at this point in time. CMS takes this data and they analyze it. So bear in mind that the preventable acute conditions causing hospital admissions, they're looking at 3 specific cases. It's going to be admissions for your bacterial pneumonias, your UTIs, and your dehydration. These are things that we're looking, or that CMS is looking to have our groups and our physicians be able to address effectively in the outpatient environment. Our preventable hospitalizations for chronic conditions, there are 3 or 4 key conditions that CMS is looking at right here. It's going to be your diabetes, your COPD or your asthma, and your heart failure conditions. Moving on, your CAHPS data. For those of you who are unfamiliar with CAHPS at this point in time, it's essentially a patient survey regarding patient experience. These are really interesting surveys that are produced by the AHRQ, and they are currently being used in quality composites depending upon certain things. Again, this is going to be one of those times where it's really important to contact CMS to make sure that you are able to identify if your group is going to be required or if your group may elect to include the CAHPS data in regards to your quality tiering. As of right now, there are PQRS CAHPS surveys that are available. These surveys are going to have 12 different groupings of question types. One of those groupings, for example, is going to be getting timely care, appointments, or information. Another group, for example, would be provider communication. Another example would be patient rating of the provider. So these are questions that are very directly going to be asking patients about their experience with their providers. An example of one of the questions is as follows. Using any number from 0 to 10, where 0 is the worst provider possible and 10 is the best provider possible, what number would you use to rate this provider? So these are very direct questions that are going to be sampling your patient groups for feedback on their experience. So we've reviewed what are the 3 sources that can compose a quality composite. Again, it's going to be PQRS information, information from CAHPS data, and then information from the 3 claims-based outcomes. And again, let me just state that these requirements may vary depending on your group size, your group type, and how you're reporting PQRS data. And then in looking forward, you can see on the right side of the screen, cost composite. Let's address that for a second. The cost composite is going to be made up of 6 cost measures, which are grouped then into 2 cost domains. This is going to be data that's derived from billing and claims, and the 2 domains are going to be related to per capita costs for all attributed beneficiaries, and then per capita costs for beneficiaries with specific conditions. Again, here we're getting a closer look at 4 specific conditions. That's going to be diabetes, COPD, coronary artery disease, and heart failure. These costs are then calculated, and then CMS is going to go and compare the performance based upon the national benchmark. Well, what is the national benchmark? The national benchmark is essentially how the rest of the peer group did across the nation. So this is done both for the quality composite as well as the cost composite. And based off of that performance, groups will then be assigned a low, average, or high award in regards to their quality and their cost. And how is that determined? That is something that is looked at statistically, and you need to be 1 standard deviation above or below the national average or national benchmark, and additionally it needs to be statistically significant and different. So there has to be a large difference there in order to win this high or this low award. So what happens next at this point? Let's take on 2 hypothetical groups in the following slides as we walk through the quality tiering process. Let's assume that one group has average quality. They have taken care of their patients and the medical outcomes. All of this has been calculated out to show average quality of care. And then let's say that our first group has provided this average care at low cost. And let's say our second group has unfortunately provided this care at a higher cost. Here we have a slide, and this is showing the quality tiering table that we've taken directly from CMS. This is how those awards of low, average, and high, quality or cost, are then utilized to calculate exactly how the value modifier will be applied. And please keep in mind that these tables are going to vary according to year, and then additionally, these tables are going to vary according to your group size as well. So this first example, you can see it's for the 2017 value modifier, and this is going to be for our smaller groups. These are going to be groups with 2 to 9 eligible professionals, as well as solo practitioners. When the value modifier program first went into effect in 2013, it began assessing data from groups that had over 100 eligible professionals. Since that time, there has been a slow enrollment or on-ramping of smaller and smaller groups. In 2014, groups with 10 to 100 professionals were assessed, and then in 2015, as you can see here, groups with 2 to 9 eligible professionals were assessed. And also, let me bear in mind with you that the performance year is going to occur 2 years before the value modifier is put into effect for your payment. That means that the data from 2015 was collected, gathered, and assessed, and then this data will determine the 2017 value modifier. The reason that there's a gap in between those years is because it allows for submission of the data and then determination of the value modifier. So again, let's look at this table one time. So 2015 was the first year that groups with 1 to 9 eligible professionals were assessed by the value modifier. You can see here, let's take our hypothetical group. Average quality with low cost. What does that mean? In utilizing the table, you can see that they will have an increase of a factor of 1 applied to their physician fee schedule. This group performed well, and they're going to be rewarded for it. And then let's also consider our group that provided average quality with high cost. You can see in utilizing the table that at this point in time, there is no penalty applied to them. This is something that's recurring with some of these programs for quality, is that in the first year of application, there is not a penalty applied for poor performance. This is something that CMS likes to being called held harmless for the first year. So this is how our groups who are participating for the first time in 2015, based off of their performance data, will have their 2017 payment value modifier determined. Let's take a look at our second 2017 value modifier table. This is going to be for groups that had greater than 10 eligible professionals. So bear in mind too, based off of what we've previously discussed, these are going to be groups that were also subject to the value modifier in 2016. So I can tell you that this table looks different this year for the 2017 value modifier than it did for their 2016 value modifier. And that's because they've participated in this program in the past. So let's take a look again at our hypothetical group. average quality to low cost, you can see here that there's a greater benefit available. We have a factor of 2 being applied to that physician fee schedule. And if we took our second hypothetical group with high cost and average quality, you can see that they have a downward adjustment that's available this year for them. Additionally, please note that the adjustments for these groups who have participated in the past, these larger groups, are going to have a greater degree of award or penalty applied to them. As opposed to the 1% and 2%, you're going to notice that this is a 2% and a 4% that's available. And one other thing that I want to discuss here before getting into the next topic. Eligible professionals, as defined by the value modifier program, are going to be any group or any professional within a group, and that's going to include physicians. So that could be your MDs, your DOs, your doctors of chiropractic. It's also going to include your mid-level providers, your physician's assistants, your NPs, or your CRNAs. And additionally, it can include certain groups of therapists, such as your speech therapists. So this is how CMS is going to define an eligible provider. So if you had one physician and, say, 9 or 10 additional mid-level providers within one group, they would be classified as a greater than 10 EP. 17. Only the physician schedule would be adjusted. Now, more recently, there's been some interesting things that have come out from CMS. And that's going to be in regards to the 2018 value modifier. We're going to move ahead to this next table. And first, let me explain some things. The 2018 value modifier has been decided to be applied to other groups than just physicians. This decision was published recently at the end of 2015 and has recently been discussed by CMS through some of their public education programs. You can see here that there are 4 specific types of mid-level providers to whom the value modifier will be applied to in 2018. That's going to be your physician assistant, your nurse practitioner, your clinical nurse specialists, and your CRNAs, or your nurse anesthetists. This is important because for groups that have participated in the past, there's going to be a wider range of of providers that are going to have the value modifier applied to them. Additionally, 2018, this will be the first year to apply the value modifier to the non-physician eligible professionals. So what does that mean? So take into consideration a small group of nurse practitioners or physician's assistants. If there is not a single physician associated with that group, the following table will be applied to that mid-level group as listed down here. Please note that it's not based on size as long as there's no single physician associated with that group. So in looking at it, you can see that since they're a first-year participant for 2018, that the group is going to be held harmless for poor performance, as seen in the bottom left-hand of the table. And then additionally, awards are possible, but they're going to be on the smaller scale. That's going to be your 1 and 2 factors. Additionally, at this time, I just want to point out something that you might have noticed as well, is that you'll, in the top right-hand corner of these tables, you'll see it's a factor of X. And in the bottom left-hand corner of these tables, it's listed as a percentage. And that is another part of the goal of the value modifier, which is to have the value modifier be a budget-neutral system. So what CMS will do is that they will calculate the total funds that are accrued due to the downward adjustments, and then from that accrued financial gain, CMS will then calculate the factors that have been awarded and redistribute the gains to those other providers. Essentially, it's a zero-sum game. So let's move on. Again, in recapping this slide, 2018 value modifier, again, for those mid-level providers, this is a table if there's not a single physician associated with the group. 2018, again, here we're looking at the same small groups. Solo providers are 2 to 9 eligible professionals, but this time this is a situation if there has been a physician associated with the group. Here you can see that because there has been a physician associated with the group who should have participated in the past, this is what the table is going to be. The held harmless will not apply here. You can see there are the downward 1% and 2%, and then additionally the upwards 1% and 2% are factors. This was done by CMS so that the smaller groups, while the rewards are not as good, the penalties won't be as severe. So this is an effort to support these smaller groups that are out there. And then moving on, looking at the 2018 value modifier for groups with greater than 10 eligible professionals. This table looks nearly identical to the table from the 2017 value modifier. But please note that in addition to the physicians, the value modifier, again, will be applied to your PAs, your NPs, and your advanced nurse practitioners. So what are the takeaways here? The value modifier is going to continue to affect Medicare physician fee service payments in 2016, in 2017, and in 2018. Then, in 2019, the PQRS, the value modifier, and the meaningful use will be incorporated into MACRA. This is important. The things that we've discussed and the measures that we've discussed are going to be folded into this new piece of legislation, which we'll discuss shortly. And where does that leave us with IBM? Currently, Insight, one of the programs we offers support for some of these PQRS measures. Our program enables real-time assessment of quality performance. This allows for actionable data for the providers. They can go in and see how they're performing on a certain measure on a daily basis. And additionally, it allows for identification of patients who are falling outside of that measure, patients that need to be reached out to. So it has a very real-world application too as far as patient outcomes. Additionally, in regards to our patients, it also allows for tracking of patients with chronic conditions. The better care you can take of those patients with chronic conditions, get them in early and often, the better care that you're going to be taking care, and they're going to have improved results. What does this mean? This means that there may be hidden implications for cost measures in a good way, such as preventable admissions. All right, we're going to move on now to the MACRA, as it's more commonly called, or the Medicare Access and CHIP Reauthorization Act of 2015. So what is this act? This is a piece of legislation that was passed by Senate in April of last year and then signed into law as well. It repeals the SGR, which those of you are familiar with was a complicated piece of legislation which perhaps did not work as well as we had originally intended. And what MACRA is going to do is that it's going to go one step further. It's going to continue to tie payments to quality. And then it also went one step further and extended CHIP funding. So that's why you see the identification of CHIP reauthorization in there. MACRA, in and of itself, has now gone and created two new payment programs. This is going to be the Merit-Based Incentive Payment System, or MIPS as it's commonly called, and the Alternative Payment Models. Now, these are going to be the two new systems by which payments are going to be linked to quality. So therefore, you can expect to see adjustments based off of quality. Additionally, something else I want to point out is the eligible professionals listed under MIPS. These are going to include your physicians, and additionally, it's also going to include your PAs, your nurse practitioners, the CNSs, and the CRNAs that were mentioned previously in the value modifier. MACRA is going to take effect starting in 2019. This is going to be very shortly. And the whole idea of the value modifier on-ramping those 4 specific mid-level providers was as a result because MACRA will encompass those mid-level providers in 2019. And when I say it's going to encompass those mid-level providers, I mean their payment fee schedules are also going to be adjusted in the same way that the physicians have had their schedules adjusted as well. So what is going to be the body of this program? Well, it's going to incorporate and modify the existing measures. So here's where the value modifier is going to pull through. You're going to see PRQS pulled through as well. But in addition to that, MACRA is also going to create new quality measures. So we'll talk more about this in a second. Here is a slide where I want you all just to keep this in mind. MACRA is going to create the MIPS, or the Merit-Based Incentive Payment System, as well as the APMs. So let's talk a little bit more about MIPS. This is a new quality-driven system, and again, it's going to be affecting the Medicare fee-for-service, or the Medicare physician fee schedule. This is going to apply to those providers who are not classified in an APM. As we've mentioned earlier, this will also incorporate the PQRS, the value modifier, and portions of meaningful use. Additionally, this will be starting to affect payments in 2019, starting on January 1. So these other payment systems for quality as listed above, those are essentially going to be retired. Their payment effects will end on December 31st of 2018, and then January 1, you'll see these 2019 MACRA and MIPS payments coming into effect. And what are we going to be looking at here? Whereas the value modifier utilized quality and cost, the MIPS system is going to focus on 4 performance categories instead of just those 2. Quality remains, but then you can also see that cost has been split out into resource use. And then additionally, we have clinical practice improvement activities. And again, meaningful use makes another surface here. So while there's been a lot of discussion about meaningful use, we are anticipating to see some form of it, again, surface through the MIPS systems. Additionally, the MIPS system is going to be set up like the other quality systems, where initially smaller adjustments will be made based off of performance, which will then lead to larger adjustments. As of right now, based off of the projections that we have heard, there is going to be a possible 4% plus or minus available in 2019, 5% in 2020, and 7% in 2021. The other thing I want to mention at this time is that the frameworks we have for the MIPS program and the APM program are already, are only in their draft phase. That being said, there's a lot that's subject to change. Additionally, that creates an opportunity for you and your groups to go ahead and take a look at some of this proposed framework and some of these proposed outlines and to give feedback about what you think and how this will affect you. So as we go through and we discuss MIPS and APMs, please bear in mind that this is all just based off of the early impressions and that CMS can fully change sort of policies that it would like out of these just proposed drafts at this point in time. And when can we expect some of this information? June 2016, I think we're going to see some MIPS rulemaking come out, and then we're going to be following the other release of data very closely to see if we can't identify other policy taking shape as it is released. Let's speak for a second about the alternative payment models. Again, this is going to be an incentive program under the Medicare Physician Fee Schedule providers. And this is going to address the groups that previously have been excluded from the value modifier. So these are going to be the alternative payment models, the ACOs, the PCMHs, and the bundled payment models. How is the incentive going to be applied here? It's going to be through a lump sum up to 5% in 2019, so that'll start then. Additionally, this will be carried out for another 6 years. After that point, right now it's projected that this may change to higher annual payments beginning in 2026, as you can see. The other thing I want to make a mention of here is that the definition of an APM is somewhat to be determined according to MACRA. There are a few phrases that have been thrown out, such as a qualifying APM, a partially qualifying APM, and then also a possible inclusion for low volume threshold. So as we're going to follow along with CMS, just bear in mind that some of these definitions may change, and this is something that we're going to have to follow a little bit more closely. Certain CMMIs may also be included within this section. All right, let's talk about the categories. So recently there has been a release of a draft document for these APMs that's available to the public, and it classifies 4 different categories of payment. And sometimes to define what you are, you have to define what you are not. So category 1 is fee for service with no link to quality. You can see that category 2 then has a quality link. And then category 3 and 4 are going to be kind of the roadmap. This is where CMS wants us to end up at, where it's going to be population-based, a higher tie to quality, a focus on the patient-centered outcomes. And I'm going to go ahead and show you this next slide. I realize that this may be a little bit small, but that being said, we want this for your reference. So this was taken directly from the draft proposal from the APMs. And you can see the 4 different categories listed here. And then additionally, you can see some examples of projections about where certain ACOs will fit in or where the PCMHs could possibly fit in as well. You can see that category 3 right now currently has a listing of a PCMH. And so as these groups get involved in these categories, the idea is to on-ramp, to make them more and more responsible for not just the reporting of data, but also then for rewards and risks for financial gains for these programs as they've been linked to quality. So where are these quality measures coming from? And to that we look to the Measure Development Plan. On December 18th of this past year, CMS released this Measure Development Plan, which really holds the soul of the program. This is a draft, as it is right now in its current form, that is available for public comment up until March 1st. That being said, it will be finalized in May after those public comments have been taken, and then they will be addressed then. So this is, again, a chance for groups to go in and look at how these measures are going to be built. So what is the purpose? This document serves as the framework for measure development. Additionally, CMS gives us an idea of the priorities that are going to be the areas of focus for where these measures are going to be developed, what types of measures they will be, and who they will be aimed at. And then lastly, and very importantly, I want to note that the measure development plan requires public reporting on the Physician Compare website. Many of you are probably familiar with that, and we're expecting to see a bigger use of the Physician Compare in the future. One other note I want to mention here is that there is a goal to make the measures that are created through this development plan that will pertain both to MIPS and APMs. We don't have the fine line details of that right now, but there should at least ideally be a core set of measures that can be developed and applied across the continuum of care. So let's take a look again a little bit at MIPS. The measure development plan tells us the priority areas. This is going to be outcome measures. What was the outcome of the A1C for your diabetic patient? Also, this is going to include specialty-specific measures. While a lot of measures at present currently apply to primary care groups, we're going to most likely see a diversification and an inclusion in specialists and specialties. So be on the lookout for that. Additionally, CMS has identified some high priority domain areas. So these are going to be the larger groupings of your measures. There are 6 domains currently listed by the Measure Development Plan for MACRA, and here are the 3 high priority ones that have been identified. Caregiver-centered experience outcomes. So for those of you who are familiar with the patient-reported outcomes measures, we can probably plan to see an extension of that here. Again, this is still just a draft and a proposal, so now's the time to get in your comments to CMS on how you think that will affect your group. Another high priority domain is going to be communication, care coordination, and then we see cost somewhat resurface again here under appropriate use and resource use. CMS has also noted that it's going to be identifying measures, tracking use, but to balance those out, they also want to develop measures that are going to be tracking underuse. So CMS is really trying to take an approach where they're going to be identifying and then realizing the impact of the new measures that they create. Here you can see the measure development timeline. This, again, is taken directly from CMS, from the MDP. The top line is the green one, so that's going to represent your key milestones and processes that are mandated in MACRA. A lot of that has to do with the MDP, and really, that, for me, is the soul of the program. That is where it's going to be dictated how these measures are developed, and really where the focus is going to be and where the data is going to come from. The items below that are in orange are going to be the pre-rulemaking process, and then those in blue are going to be the federal rulemaking process. So here, those are going to be the dates where we really are expecting some definitions about policy, especially in regards to MIPS, where that should be developed from. So for your convenience, what we've done is we've gathered together all the different places from which you can submit your comments in regards to some of these projections. And there's going to be an online resource, an email box, and as well a postal address where you can submit your comments. And what's nice is that CMS really does go through, they look at this, and they post responses either through the Federal Register or through other places so that you can have these concerns addressed and perhaps have an influence on the way that this policy is going to be developed. So this will be really important for groups that are wanting to have an influence over a certain measure or feel like there's a certain priority that also needs to be focused on. So in review, we're going to go back to this original diagram where we talked about MACRA creating MIPS and APMs. And again, I just want to emphasize that PQRS, VM, and meaningful use are going to be incorporated into MIPS. While the programs themselves may officially end, MIPS is going to stand upon the measures that have already been created. Now, there's going to be an extensive process also to identify where care gaps are and to identify measures that can identify those gaps and to bring healthcare up another step. So those programs are going to be incorporated into MIPS, again, starting 2019. Then looking down at the APMs, you're going to see a lot of these CMMI groups, the ACOs, the SSPs, and then again, your patient-centered medical homes being incorporated under the payment system that is set up by the APMs. Additionally, the APMs have yet to be defined. We're following closely for that information. We do know that there are going to be thresholds, now whether that's patient or payment form. And then additionally, there's going to be thresholds too included under APMs about, is certified EHR technology being utilized. So you see a little bit of that surfacing in this program as well. And then additionally, APMs, from what we can tell, there's a potential for them to be required to be risk-bearing entities, or on the other hand, there's a possibility that instead of being risk-bearing, the patient-centered medical homes could also be introduced into the APMs under this wing. So what we have had in the past will continue forward in the future. There just may be some redefining and shuffling around. And then again here, we have these double arrows indicating that the measures that are created from the measure development plan should be applicable somehow to both MIPS and APMs. So again, the idea of creating a core set of measures is being followed through. So what does that mean for us? Where are we headed, and what is going to be changing? The significant changes is that we're moving forward. Think about that HHS goal of tying more and more quality and payments together in the future. So what can we expect? It's going to be a period of rapid change. CMS has boldly come out, stated these timelines, and there's going to be a need for all groups to follow closely with what's going on. So where do we think CMS is looking? These are statements that were taken from the measure development plan that really kind of capitalize and form a capstone almost on the goals of what these measures will be. And you can see that there are some very ambitious things listed here. We're going to take a minute and just walk through these. For example, CMS wants to follow the trajectory of patients and populations with chronic conditions across care continuums. So this is going to be a heavy emphasis on the chronic care, patients with multiple chronic diseases, and then additionally, not just in the outpatient setting, but through all the different phases of care that that patient might experience. This goes back to one of the ideas that there needs to be a larger goal of shared responsibility across different providers and across different groups for the outcomes of our sicker patients. And in regards to outcomes, what's going to be emphasized? We talked about the PROMs, the patient-reported outcome measures. We expect that this will take on a heavier emphasis. And then eventually, we expect to see a transition of population and global-based payments somewhere down the road in the future. We've talked about, again, the patient-centered outcomes, including care coordination, appropriate use, and, meaning overuse and underuse, and then multiple levels of accountability. Again, multiple providers across the care continuum need to be looking out for their patients. That's going to be your individual clinicians, your group practices at the system level, and then higher up at the population level. EHR data is still going to be generated due to workflows, and CMS is going to be looking also to find out what measures they can develop from naturally generated data to try and reduce provider burden. So that is something that has been taken into account as well. And then a variety of payment models should be incorporated into this rulemaking and measure development process. CMS has gone out of their way to incorporate private sector, meaning the health insurance companies and other key stakeholders, to try and global input on this process. So there is possible that this could have multi-payer applicability down the road in the future. Again, just thinking on this concept, this is a far-reaching, ambitious move to population healthcare. And lastly, this is very interesting too, the stratification of results by demographics. CMS is hoping to identify if there's any disparities or any particularly vulnerable populations. They're going to be looking at race, ethnicity, and gender. And so that's going to be data that we can expect to be collected in the future. And then also utilization of CMS Physician Compare. This is going to continue to take on a stronger and stronger role as some of these measures may be reported. Performance adjustments to those pay schedules could be reported here in the future. So what are the implications for our providers? The new law, literally the new law, is that physician payment under Medicare Physician Fee Schedule is going to be changing. The value modifier for the 2017, which we reviewed, is going to be based on your 2015 data. That's already over and gone. The reporting periods are still going on, but however, that data has been completed as it exists. The value modifier for 2018 is based upon the 2016 measures. There are still some changes and adjustments being discussed right now, and so we'll be very closely following with what the new developments are in regards to those. And then, if we've already discussed 2017 and 2018, that leads us right up into 2019. Macro payments are going to be starting much sooner. We're going to be feeling the effects much more rapidly than I think we're anticipating or that people are prepared for, which is really one of the reasons we're doing this webinar today. We want to equip you with what is coming, and we want to be able to provide you with what we can do to help walk you through that system. So IBM Watson Health, we are absolutely here to support the new payment incentives. We have measures which we update and that are available for quality and resource use, and then additionally in supporting clinical practice improvement activities such as the patient-centered medical home. So what are our next steps? Things that we currently offer, blog postings. We address some of these outcoming announcements and updates through our blog posting. And then additionally, we'll continue with producing webinars with relevant information as it's released. And then the timeline for 2016. Again, as I mentioned earlier, March 1st is the deadline for public comment for the Measure Development Draft Plan. And again, that's really going to be the heart and soul of MACRA, since it's going to outline what is the priority for the measures, where are we going to be looking for this data. May 1st is when that measure development plan should be out and finalized, so be expecting more information to follow on that. And then November 1st of this year, we're going to have a final rule on some MIPS measures available is what we're anticipating. So we're going to be following along very closely so we can be on top of these new developments as they are announced. At this point in time, if you've had any questions about some of the material presented, please feel free and go ahead and use the chat feature.
Actually, thank you, Laura. Actually, the questions feature is better.
Oh, I'm sorry.
No problem. That was excellent. Thank you so much. That's a lot of material. We have lots of people on the line and lots of questions. So we're going to go back and ask you, Laura, to help clarify some points you made and to address some questions that people have asked. So first of all, can you just remind people about the tables that you showed, for examples of the how the value-based modifier is going to be applied? It was a little bit confusing as to whether the 1x and 4x were about the, how that's going to work. Are we saying they're going to get double the payment or half the payment, or is that still relating to a percentage change in the fee schedule?
Absolutely, and thank you for that question. So the tables that have the 1x, the 2x, or the 2x and the 4x, which were also represented in percentages, are going to be the percentage change to what is billed under the physician fee schedule. So that's going to be 1, 2, or 4% of that average billing. So that's how that is going to be applied. Now, it will be determined on a group level, depending on how you're reporting. If you're reporting PQRS measures as a group, it will then be applied to that physician fee schedule for all the physicians within that group. So, excellent question. It will be a percentage change to that physician fee schedule. And the 1x, 2x, and 4x merely represent the distribution of the awarded reimbursement for good performance. So keep in mind that's not a multiplier of the whole fee schedule, but rather those X's represent a factor which is to be determined, because whatever money is garnered from the groups that did not perform well, it will be redistributed according to those factors to the groups who did perform well.
Thank you. That's very helpful. Also, we made lots of references to meaningful use in the slides, and there's been a lot of press lately around the future of meaningful use. So can you please clarify?
Yes, absolutely. So the value modifier in and of itself doesn't necessarily collect meaningful use measures at present, but keep in mind that the meaningful use program is still ongoing. So there are several quality programs which could affect your payments now. In the future, under MACRA, MACRA is going to have those 4 performance categories. Value modifier have the 2, cost and quality. MACRA will have the 4, and that's going to include meaningful use of certified EHR technology. Now, exactly how those measures are going to be determined and what is going to be assessed through that category has yet to be determined, but if you do have an opinion, now is an excellent time to be giving that feedback to CMS as they are looking for that type of feedback right now from the public.
That's great. So, okay, thank you. And can you also remind us when mid-levels will be impacted? It's not until 2018, correct?
Yes, that's correct. And again, it's not going to be all of your mid-level providers in regards to the value modifier. Now, there are other issues in regards to PQRS, so we'll leave that to the side today. Let's focus on the value modifier. The value modifier will incorporate the following providers. It's going to be your PAs, your NPs, your CNSs, and your CRNAs for the 2018 year. The extension of the physician fee schedule will be included to them, and so that is precisely what will be adjusted for them. So for groups that have a very large number of those types of providers, this is going to become increasingly important since more of the employees of the group, so to say, are going to be affected by this adjustment that will be made to their reimbursement schedules. Now, in addressing MACRA and those mid-level providers, it's going to be those same 4 mid-level providers at this point in time, since MACRA is still just in the draft phase of development. But again, the idea that the value modifier had was to on-ramp those providers early, so that way the transition to MACRA would be smoother for them. So again, one more time, just to clarify, it's only going to be your NPs, your PAs, your CNSs, and your CRNAs. I do expect that there is going to be some more clear definitions of exactly what types underneath that category will be delivered by CMS or may already be available, but there should be some very fine definitions available to the public.
Thank you. The questions just keep coming in, and I just want to tell everybody that's great, but there's no way we're going to get to all of them. They are great questions. So I'm trying to select some that I think will have the broadest appeal at this point. One question, Laura, that we may not know anything about yet, but if you've come across any information about how EPs are eligible providers that are in ACOs today, that their term expires maybe, let's just say in 2017, that ACO contract might be finished, would they automatically go into MIPS? Or do we know anything about that, or how this transition will be impacted if they don't continue in some kind of APM? And it's okay if we don't know, but that was a great question, I thought.
Yeah, and I do think that's a really good question. In regards to an ACO, being designated or not in 2017 and how that will affect their MACRA payments in 2019 is really yet to be determined. We are eagerly awaiting some fine definitions of exactly what will classify as an APM. So that's something we're going to be following along very carefully for. Now, in regards to the value modifier, 2017 will be the first year that SSPs have the value modifier applied to them. Presently, that seems to be really the only ACO that's been participating. Some of the other ACOs, such as NextGen, Pioneer, etc., have been waived from the value modifier. So again, I would be looking more towards MACRA and the definitions they release. And then always, just as a caveat, always check with your quality program if you need to be submitting any extra data for the value modifier, especially since some of the data that's required for the quality composites may vary depending on what type of program you are. So I can't emphasize that enough. It's so important. And the help desks that are available, such as QualityNet, are really of a high value. So please, please, please look online, look and reach out to CMS for further clarification of what you need to be doing in order to be a successful reporter.
Okay, excellent advice. Regarding bundled payments as one of the alternative payment models, which types of bundled payments are included?
And that, again, I'm just going to have to say, I think we're still looking for a definition from the government as far as what that APM is going to be inclusive of. Again, we have some general guidelines. It's going to need to be something that's risk-bearing, which would apply. But these are things that we're eagerly following along for to see what the final word is going to be and policy is going to be from the government.
And we got this question several times, Laura. Did the materials and the conversations you've had with CMS reveal anything about FQHCs and the impact on FQHCs relative to these programs?
That's a really excellent program. And again, I haven't seen anything specifically that speaks to FQACs and the value modifier or MACRA. It may come down to, and things can get very complex very quickly, whereas if you have a physician who's participating in an ACO in one group but is also, doing 1 or 2 days out of the week over at an FQAC. So that, again, unfortunately, I don't have a good answer for, and it's really going to be a case-by-case basis.
Okay, thank you. And then let's see. So several questions have come across around, okay, given all of this information, what is the most proactive thing, or what are the 2 or 3 most proactive things that providers can do? So some people are wondering whether, gee, do we need to focus on all 34 quality measures in 2016 in order to do better in 2018 on the value modifier? Do we need to, what are the other things that we should do?
That's an excellent.
Yep.
Yeah, that's an excellent question, because these programs are far-reaching and there is so much data that can be garnered in regards to your quality composites and your cost composites. I think a good approach is starting with PQRS and finding out exactly, if you're in a specialty group or a quality program, finding out exactly which measures need to be reported. That's also going to be influenced by your methodology of reporting for PQRS, so bear that in mind as well. And I think that looking at the measures, deciding which are the ones that you're going to focus on, certainly is going to help you take better care of your patients, so I think that's a great start. So absolutely, getting ahead of the ball, getting aggressive with your clinical care, finding out where you can perform better, maybe where you've not been performing as well in the past would probably be a good first step.
And that's excellent advice. Do we have any suggestions for groups where the physicians are currently paid a salary as opposed to fee-for-service, and how to keep physicians engaged in this program, since the measures might not as easily impact their direct pay?
Absolutely, and that's a really great point too. In regards to that, as we mentioned earlier, the value modifier is going to be affecting those Part B payments for the physician fee schedule. So in the situation that you have a physician who's not being paid through that methodology and is perhaps being salaried in a different way, these measures are still going to be important. And what it's going to come down to is that MACRA in the future will somewhat incorporate the value modifier and the measures that are there. Certainly those are going to be open to revision and modification and new measure creation. However, that being said, the private payers have been thoroughly identified as a key stakeholder for MACRA and for the measure development plan. So these companies have been included and invited to the table for a few key groups that have been created by the measure development plan, such as a group called MAP, the Measure Application Partnership, also the Core Quality Measure Collaborative, and then another organization, the Healthcare Payment Learning and Action Network. And these groups are really going to have a hand in influencing and have a say and a seat at the table in discussing how these measures are developed. And so I think long term, especially with MACRA, seeing an adaptation or an extension of these measures with the goal of creating that core set of measures, it could come into effect. So looking at what's going on now will definitely be advantageous into what's going to happen in the future, even if you're looking more on the private payer side.
Thank you. And I want to just close with our last question topic, and that is on the patient-centered medical home. As many people know, we have at Cytel and IBM Watson Health, we continue to support the patient-centered medical home model as we have for years. And Laura, if you could comment a little bit more on what we know about what that might look like, and how NCQA recognition potentially could play a role in whether people should continue to keep up their NCQA recognition. Or any other recognition. I didn't mean to just single out NCQA.
Absolutely. That's a great question. So as far as the patient-centered medical home goes, we know that for MIPS under MACRA, that the development in trying to become one is going to most likely be recognized under the clinical practice improvement area. So for the efforts that, if you're not there yet, if you want to try and reach out to that point to become a PCMH, that is going to help you maximize perhaps that one category out of the 4 that's going to be available under MIPS. So becoming one in the future could be important. And then if you're already one now, we have heard and seen that perhaps the patient-centered medical home will play a very large part under the APM. So I think that maintaining that certification, so that way you don't have to go back through the process later in a few years when you want to reestablish yourself, is probably a really good idea. We know that this is something that's going to be addressed very specifically, and there may, be a better definition. Again, as I mentioned earlier, those qualifying APMs. We're going to have to see exactly what those thresholds are, but maintaining a status that you have, and certainly as we're moving to these quality payments, it's going to be a good idea to upkeep those certifications.
Thank you, and I just want to confirm that at this point in time, there is nothing in what we've seen so far that singles out any particular type of recognition, like NCQA. However, it appears that along the lines of how important it is to have team-based care and have quality improvement processes in place, and all of the things that are part of a high-performing medical home are going to help you be successful in any APM model. So I think that is the general direction and encouragement that we are seeing so far in what's come out. Is that a fair statement, Laura?
I think so, yeah, absolutely. And again, we're going to be following very closely and hopefully be able to have that information available soon within the year.
Well, that's excellent. Well, thank you, everybody, for joining this call, and we will do our best to answer the questions that weren't directly answered during this part of the webinar. And I'm going to turn it back over to Sean.
Perfect. I'd like to thank both Laura and Sharon for their time today. As a reminder, you'll receive a follow-up email that includes this presentation and a link to the recording within 2 business days via the email you registered with. Also, please take a second to take the brief survey when you log off the webinar. We would love your feedback on today's presentation. At this time, the webcast is ended. Thank you for attending and have a wonderful day.